Welcome back, everyone. It is 2:45 p.m. Eastern Time, so we are going to go ahead and get started. Thank you for those who responded in the chat to our question about how you measure the extent your respite services are person and family centered. Encourage you to continue to think about that and share that over the next few minutes here if you didn't get a chance to respond. And also want to just call your attention to the fact that in the respite model description tool that was developed by the CAR, that's in the Common Data Elements white paper, we do have a section where we have some recommended questions for self-assessing the core concepts around person and family centeredness that are adapted from the Institute for Patient and Family Centered Care and informed by the National Center on Advancing Person-Centered Practices and Systems. So I encourage you to check those out and adopt those as you feel appropriate for your programs. So Marcia, if you could please pull up our slides for the second half here. We are so excited that we have an amazing panel of experts who are going to share information about emerging national, state, and local respite services evaluations. On the next slide, you'll see our panel presenters listed here. Again, you can learn more about each of them in the bios that are posted on the ARCH website. But we're excited to hear from Becky Utz, Joe Gaugler, Sarah Harrigan, Amy Nazaire, and Linda Weiss, who are going to share about different projects that they have that are things we can learn from on a large-scale evaluation of respite services. So without further ado, I'm going to introduce our first presentation for our panel, which is going to be on the Center for Dementia Respite Innovations, and we are joined by Becky Utz and Joe Gaugler. So I will turn it over to both of you and looking so forward to hearing your presentation on this exciting project. Thanks so much for being here today, both of you.
Well, great. Thank you so much, Kim, Jill. I'm always so excited to work with ARCH on a number of different initiatives over the years, including this newest one, the Center for Dementia Respite Innovation. So our goal here today, really briefly, is I'm going to provide a really basic overview of the CDRI for short. I'm currently Associate Director of the CDRI. It is directed by Sam Fazio at the Alzheimer's Association. Mary Eck from Us Aging is also an Associate Director currently on the CDRI. And then we're going to get into more detail of the evaluation plan. And Dr. Becky Utz will provide more insights and details as to the evaluation plan. Really a very accomplished researcher in respite and respite research. We couldn't think of anyone better to oversee the evaluation of what I think is a very exciting initiative. Next slide, please. Here you just see some basic information for both of us, titles, etc. Next slide, please. So this project is funded by the Administration for Community Living. You see the disclaimer statement here. It was a large funding amount, but what was exciting about this for me and why I was so grateful to ACL, and certainly all of us were, is that this is a funded initiative where really the bulk of funds, and when I say the bulk of funds, it would be roughly 80% of all the funds go directly back to programs, respite programs themselves. So in that regard, I was very excited to even play a small role in this because of its potential to actually result in real world impact. Next slide, please. So again, we're going to talk about the CDRI, review the evaluation plan. Dr. Utz will go into more detail about how the evaluation plan aligns with ARCH's value of respite model, as well as the very important Common Data Elements initiative that ARCH has championed and led. And as time permits, we'll certainly answer any questions and hopefully engage in a useful discussion as well. Next slide. All right, so again, the Alzheimer's Association, in collaboration with those of us at the University of Minnesota and Us Aging, was awarded a $25 million grant to really enhance respite services for both caregivers of dementia as well as people living with dementia across the country. So the CDRI, its goal again, and again, 20 million of the $25 million over a 5-year period are to go directly to community-based respite programs to really enhance their availability and to build upon current innovation as it relates to delivering person-centered dementia care. Our goal is really to not only develop and then potentially pilot cost efficient, effective, but most importantly, strengths-based person-centered approaches that really pushes the envelope in how we care for people living with dementia and hopefully elevates a lot of the current innovation that's currently going on in respite programs such as yours across the US. Next slide, please. So there are two sets of awards that are given out as part of the CDRI. So the CDRI was originally funded a year ago, roughly, this month. And so our year one awardees have been notified. That was done back in the summer. I believe our next call for applications will be occurring again in the spring, roughly. And there are two awards that respite programs who are providing dementia-related services and supports are eligible for. The first are startup awards. You can see those are from the $50,000 to $150,000 range. So these are for new dementia-specific respite providers. And then finally, we have pilot awards, which are funded up to the $250,000 range for a year. And these are really designed to build upon existing, exciting, innovative dementia-specific respite programs and adding on innovative components, adding on, maybe different approaches to reaching communities that heretofore have not been to, again, provide person-centered, strength-based respite care for people living with dementia and their care partners. Next slide, please. So one of the things we really wanted to build as part of the CDRI is robust support. It was more than just simply providing funds and then not offering the necessary technical assistance to ensure that the funded projects are as successful as possible. So some of the post-award support activities that we provide, you see listed here, these will include community listening sessions, where local association chapters are going to work with both recipients and local area agencies on aging to really get a better sense of community respite needs, and then also to obtain feedback on the awardees' approach to services as supported by the CDRI. We're also developing a series of education resources. For example, fundamentals of person-centered dementia care training module is one example. We'll also be doing a bi-monthly webinar series. One of the topics will focus on sustainability, and these topics will evolve over the subsequent 4 years of the CDRI. Finally, every other month, we'll also offer peer-to-peer discussions, kind of building almost a small learning collaborative of awardees to learn about what's working, what's not, and to help really refine and tailor existing dementia respite programs. So again, that they can exert the most benefit as possible. Again, one of the benefits of having the association lead the CDRI is its very formidable marketing infrastructure that we can rely upon that, again, will raise awareness of respite services and highlight the benefits of respite for people living with dementia and their care partners. And again, we also offer very robust technical assistance. For example, Dr. Utz, in her role as evaluation lead, is available to help guide and assist programs in terms of successfully completing the data collection activities as part of the evaluation. Myself and Sam Fazio and others are also available to provide any support needed to really just ensure that the programs are funded appropriately, they're making the right kind of progress as expected and hoped for, and to really also develop any kind of individualized technical assistance plans as needed. Next slide, please. Here you see the year one timeline, which I reviewed briefly. We're probably going to be following a very similar timeline for year two. For those of you that did apply for year one and maybe by chance you didn't get funded, I highly recommend you apply again. Again, we're going to be funding at least 10, it might even be up to 20 programs a year. Forgive me for not knowing off the top of my head. So there is, clearly a lot of funding to support a number of awards each year, and depending and contingent on availability of funds, highly recommend those of you pursue CDRI funding. And I know several people on this call would really very much like some of you specifically to apply. I'll call you. See, you're on the call. I know Doris, she participated in our program, participated in our ADS Plus project. Obviously, I think you'd be a great candidate for this as one example, as would many others of you too. Yep, you should do it, Doris. And reach out and use the CDRI resources if you're thinking about, here's what we want to do, here's what we're thinking of applying for. Is it the right fit? Should we do a startup? Should we be a pilot? Use these resources to help position your application as best as possible. So again, these are really the timeline for year two. I anticipate it's going to be very similar as time one. It gives you a sense. We will have in the spring another information and support webinar. The goal being, the application will be due June 1st. By July 1st, beginning of fiscal year, you'll be notified of award. Next slide, please. Here you see who's eligible: domestic, public, or private, for-profit or nonprofit entities. Then identifying a lead staff member to participate and lead the initiative. We really, really require that if you're part of this is that, the leader, as well as often, ideally, additional staff members involved in the project, team leads, team members, should participate in all the learning and support activities of the CDRI, okay? Here you see as well, you have to contribute a required match of 25% of the organization's total award. I think that's fairly standard for ACL types of awards. And again, you should be currently providing or prepared to provide dementia-related respite services and kind of understand and know what does that actually entail. Okay. I wasn't involved intensely in the review process. I didn't think I was the right fit for this, being a researcher primarily. But nonetheless, my sense was applicants who were just kind of tacking on a dementia thing to existing programmings, but didn't really quite understand what does that mean? What does that entail in terms of providing services to this community that often resulted in a less successful application. Next slide, please. So you see we had close to 200 applications submitted. Generally, as each year goes on, fewer applications are submitted. We had a big wave of them. You can see the top submissions by state throughout the US. The type of entity, most nonprofit, but not all of them. Around 1 in 5 were for-profit. And then 8 and 10 currently offered respite services. Most of the funding provided was for pilot funding, but then around a little under 30% were startup fund requests amongst the applicants anyway. Next slide, please. And here you see the grant recipient funding. We tried very hard and we were deliberate in ensuring that the entire US is represented in terms of respite providers across the country who applied. So we wanted to ensure that we had that geographic representation that included, where possible, rural communities, those that predominantly serve low income respite, as well as many other underrepresented communities as well. We did the best we could with the applicants who came through. My hope is, as we continue learning and proceeding with the center, that we can offer the resources of the CDRI to help maybe applicants who weren't quite as comfortable with the application process, had questions, maybe didn't understand certain aspects of it. We had to launch this and get it off the ground fairly quickly in year one to get those year one programs supported. I am hopeful that as the center progresses, that we can ensure that we are inclusive in who we're supporting, so that we are reaching as many heretofore underserved communities, individuals, families that we haven't to date. Next slide. So if you want more information about the CDRI, I realize you'll probably get the slides anyway. If so, there's the website. If you have a phone, feel free to scan the QR code as well. I think someone was kind enough to put the web link in the chat as well. I'm going to turn it over to Dr. Utz now, and she's going to talk more in depth about the evaluation plan. So Becky, please.
Thanks, Joe. And Kim, can you remind me how much time do we have for our presentation?
You have 20 minutes total, so you got about another 10.
Okay, perfect. Go to the next slide here. So I'm going to talk a little bit about the evaluation. And because there's a very sizable amount of federal funding to support and to create CDRI, there isn't a requirement to do an independent evaluation. So I, at the University of Utah, not connected to Minnesota, not connected to the Alzheimer's Association, am serving as the independent evaluator of CDRI and the activities associated with this grant. So we are, in terms of this evaluation, we are trying to understand the impact of these dementia-specific respite services on the quality of life, as well as the quality of life of caregivers and persons living with dementia, as well as the overall success of the center's activities. Next slide, please. And this there's a whole lot of words on this table, but this is the basic logic model, or the generic logic model that we use to guide the independent evaluation of CDRI. Now, the strategies and activities are a lot of what Joe just talked about in terms of providing that support, providing the technical assistance to the people that are providing respite, dementia-friendly, dementia-specific respite services. The outputs then are also related to, can we provide dementia care educational materials? What types of recipients are using these? But the most important part of the evaluation that I want to focus on today are the outcomes. What are the outcomes that we see from the CDRI activities? And we use the PRISM model or the RE-AIM model in order to identify some of those important outcomes. So the first set of outcomes are just about reach. How many programs are applying and how many programs are awarded? Secondly, what are the number of new clients that are served by this federally funded initiative? What kinds of clients are served? The effectiveness, this is really, I will go over some of the outcomes that we are looking at in terms of, can we really change the quality of life, the well-being of caregivers, and also possibly the persons living with dementia? And then also, because a lot of this work is about providing resources and education and training, we also are looking at staff. Can we change the self-efficacy, the competencies and confidence of staff that are providing respite, and particularly the staff's ability to provide services in or for a dementia-specific population? Adoption, we're going to look at the percentage of respite providers that are able to implement these innovative programs that they say they're going to. Implementation, and finally maintenance is, are these programs able to create respite models that can continue after their funding has ended? Are these sustainable? Are these things that they can continue doing? So this logic model overall, and particularly the RE-AIM, the reach, effectiveness, adoption, implementation, and maintenance, these outcomes are the important characteristics driving the independent evaluation of CDRI activities. Next slide, please. So using that, I want to mention a few things. This project and the evaluation effort of it is deemed non-human subjects research. We went through the University of Utah, which is guiding the independent evaluation. We went through the IRB process and they said, no, this is all evaluation. We do not consider this human subjects research. However, from an evaluation perspective, we still wanted to follow all best practices of human subjects research data collection. That would be things like anonymity, confidentiality as much as possible, protection of data. But then we also, in order to do some of this best practices around data collection, data management, data security, we did build our entire evaluation system in something called REDCap. It's an online secure data collection and tracking system. This allows us to link all the data that we collect from individual staff and clients to each organization. It allows us to link pre and post measurement, because we do have repeated measures of staff competencies, of outcomes measured at the level of the caregiver. So REDCap allowed us to organize everything. So it's set up very much like a research project. We have all the safeguards for data security, data management. All those best practices are in place, even though IRB says, oh, these evaluation efforts are not considered human subjects research. Next slide. So what we do, and there may be, click on some things. I think some things are going to highlight here, and I'll talk about each one. So what we are looking at, first, we are going to evaluate and track and monitor all of those technical assistance resources that are being created by Alzheimer's Association, US Aging. We're just going to look at how are they used, which ones are most effective. Next click, please. In terms of the organizations, we are asking each organization that received funding to describe how many clients they served, including all the characteristics of those clients, how many professionals they trained over the course of the year of funding, and then also how many hours of direct service they provided to caregivers and to persons living with dementia. We will do initial survey and exit interviews. Next click, please. From the respite clients and the staff, we also have a pre-post kind of research design or evaluation design. So of the staff, we are asking them at the baseline, so right upon start of the funding that they've received, as well as 6 months in and then a year later. And each staff is going to fill out their dementia awareness and competency. And with the respite clients, we're asking them upon intake of the new respite program, and then at the end of the funding period, or when they finish receiving respite, we're going to ask them some basic standardized questions about their quality of life. Next slide. Okay, so what I want to quickly go over is our model and the kinds of outcomes that we used and how it aligns with the ARCH value of respite model. Next slide. I know that there were whole presentations on this yesterday, so you saw this. In terms of the value of respite, we really are trying to get a comprehensive overview of who's receiving respite, what are their circumstances in terms of caregivers, as well as the outcomes associated with respite. Next slide. And as we look at this value of respite model, the common data elements have been outlined. What are some of the things that we want to measure? In the CDRI evaluation, we've tried to touch upon most of these. So I'm going to go over a few very quickly. Next slide. The first thing that we do is trying to understand who are the clients being served. So we have used in CDRI a standardized reporting form that is the OBM standardized reporting of how many clients have been served, and it breaks it down to all the demographic characteristics of the person living with dementia as well as the caregiver. Now, you can see on the left-hand side of this standardized form, we're asking for every client. Remember, there are two people in the case of respite, a caregiver and a person living with dementia. Their age, gender identity, whether they're transgender, sexual orientation, geographic location, ethnicity, race, minority status, intellectual and developmental disability, veteran status, and there are a few others that are cut off. This is challenging. And in order to do this, we have created some resources for organizations of what should your intake form look like to collect all of these context variables of the people that you are serving. We have created dynamic tracking sheets so that organizations can really say at the end of the year or even 6 months in, here are the characteristics of the clients that we served. Most of the respite organizations do not collect this detailed information about the clients that they served. But in order to provide comprehensive evaluation of the demographic characteristics, we need to help them set up their intake forms from the start so that we can report that. The other thing that we're doing is each professional or volunteer that is working with the respite agency, there's another set of forms of just what kinds of professionals are involved. This is the standardized list ranging anywhere from information on referral providers to students to clergy, just trying to put the professionals into these different buckets of what kinds of professionals we have. Next slide. The other thing that we did in terms of the caregiver outcomes, one, we are not trying to collect data from the person living with dementia. We decided for our clients and the quality of life, we'd focus only on the caregiver, collecting data from them. We created a revised survey that includes some of your standard measures of burden. We also have a positive aspects of caregiving. So just to balance the positive and the negative reactions and experiences of caregivers. Same thing with well-being. We ask about their global health and we ask about negative affect, which would be around depression, anxiety, those kind of feelings, but also positive affect. How enthusiastic, how engaged do you feel in life? We then also ask them how engaged they are socially with friends and with community as an outcome. And then finally, looking at how do the caregivers feel about their desire to institutionalize. With the caregiver outcomes, all of these are measured pre and post. So we try to capture the outcomes of the caregiver at the start of respite and then at the end of the funding period or when they end their respite period. One thing to note, we have tried to have a comprehensive set of outcomes However, we did not necessarily always use the full standardized scales that you would in research. So instead, we picked 4 or 5 burden items to create a burden scale, just to create a shorter, more palatable survey for the people that we were organizing, instead of having an entire index or scale to measure depression or anxiety. We chose 1 or 2 items of each. It just was the burden that we were asking, the burden that we're potentially placing on them. We wanted to have a shorter survey. For the staff outcomes, again, measured in a pre and a post fashion, we asked them a single scale of, it's the CODE scale, but it's their competencies and confidence working with persons living with dementia. Now, one thing I want to point out here, we did shorten many of the research scales to be shorter. The other thing that has been requested by the 20 recipients that we are doing this evaluation with on cohort number 1, we're up to 6 languages that have been requested for our caregiver survey. Many, about 7 out of 20, have requested Spanish, but we've also had a couple of requests for Russian, Korean, and Vietnamese. So we're working on trying to translate some of these instruments and working with organizations to think, can we do a facilitated, translated interview to get some of these data from the Respite clients, from the caregivers. So with that, I will just end on the final slide here, is to show that in that comprehensive common data elements, and you can click through it, I think there's some things that'll pop up here. We have tried to get demographic characteristics of the caregiver. We have tried to, next click, you can just click a few times. We've tried to get the demographic characteristics of the person living with dementia. Again, we had to help each of these organizations create new intake forms to get this information. The outcomes that we mentioned, we reduced them to their essence of maybe just a few items to get at a multi-dimensional set of outcomes. So with that, and you can go to our final slide, we have tried to be as comprehensive as possible in terms of this evaluation effort and invite us back in a year or two, or maybe at the end of 5 years. And I think that we hope to be able to show you some of these empirical outcomes and assessment that we see from the CDRI outcomes that we just reviewed, as well as identify some of the best practices and innovative models of respite care that we're seeing by the organizations funded by CDRI. So thank you.
Thank you so much, Dr. Gaugler and Dr. Utz. That was an incredible overview of such an exciting project to have funding to support piloting respite and evaluating it, and you did just an excellent job framing that on the CAR work. And Dr. Utz and Dr. Gaugler are both part of the CAR, so I'm glad that they were able to leverage that as well. So had a little leg up on some of the other presenters because they were a little more familiar. But thank you so much. We're going to go ahead and save questions for the end in our Q&A for the panel. But if people have questions they want to post in the chat now, please feel free to do that. And our panelists can also, kind of look at those. If it's something easy to respond via chat, feel free to do that. Otherwise, we'll try to get those during our Q&A. But let's move on to our next presentation. We are so excited to have Sarah Harrigan and Amy Nazaire, who are going to be presenting on the Massachusetts Respite Innovation Grant. So I will invite them to share a little bit more about themselves and their presentation.
Okay, thank you so much, Kim. It's great to be here. You can move on to the next slide, please. So just quick introductions. My name is Amy Nazaire. I see a lot of familiar faces and a lot of and names and many new ones as well on this call. So it's super exciting to be here. My day job is at the Massachusetts Department of Developmental Services, and I'm one of 4 regional managers who work with folks who are self-directing and managing their own services. But for many years, I was one of the family support directors, and in that capacity got involved with the Lifespan Respite grants and project and with ARCH. So I remain the principal investigator for the Massachusetts Lifespan Respite Grant, which is hosted by DDS. We're on our 6th consecutive grant. We've been grantees since 2010. So it's very, very exciting to see how much growth there's been in this field over the last 14 years. And I'm joined by Sarah Harrigan, who is, and Sarah, hopefully I'll get this correct. She's a senior consultant for aging and disability services at Public Consulting Group, which is, you can probably explain better than I can the scope of PCG, Sarah, but they're a national consulting organization that does a lot of work in the human services field. Is that accurate, Sarah?
It sure is. Yeah. Thank you, Amy. Sorry, I was having a little technical difficulty. So
No worries.
On my phone.
So Sarah is yep, sounds like your sound is a little bit in and out, but Sarah is leading the team that's consulting with the Massachusetts Executive Office of Health and Human Services, which encompasses DDS as well as many other agencies, to conduct the TA and evaluation of this set of ARPA respite innovation grants that we're going to be talking about today. So next slide, please. So just a little bit of background, you can click through to the next slide. So bear with me one second. Got too many screens going at once here. So Massachusetts was, we were very, very fortunate to leverage some of the one-time HCBS ARPA funding back in 2022. I think this whole project started at some point in 2022 to issue an RFR, which we'll talk about in more detail in the next slide. But EOHHS, our Executive Office of Health and Human Services, committed to using a pretty significant chunk of our ARPA funding to fund these respite innovation grants, the respite innovation grants. And it was very, very exciting for us at the MLRC, the Mass Lifespan Respite Coalition, because really this was a very significant way to build upon some of the previous work we had done in past years when we had awarded 3 rounds of lifespan respite mini grants, respite innovation mini grants at a much smaller funding level, but had done some evaluation and begun to really look at that, to look at those mini grants in terms of replicability and best practices, et cetera. So this was really a much larger scale to build that out. I noticed that a number of our innovation grantees are actually on the call today, so that's really great to see, as well as a number of other people from Massachusetts. So the funding was used, and it was a total of $20 million. So, you know, pretty significant funding was used to develop a competitive grant program with several goals in mind: to enhance, improve, and expand respite services, test innovations in order to identify promising practices, close service gaps, and provide person-centered respite in home and community-based settings. And really to make sure that we were really maximizing the long-term impact of this significant investment, those of us at the MLRC, the Respite Coalition / Respite Grant, really took the lead in advocating to EOHHS at the state level to utilize some of these funds to engage an organization to conduct an evaluation of the grants. And PCG was the perfect fit, Public Consulting Group, since we already had, as a state, an established relationship with them. So it was really great. And Sarah will go into a lot more detail about where they're at with the evaluation. It was also, we were very excited about the opportunity to align this work with all the amazing work that CAR is doing, as well as a number of other initiatives that are occurring in Massachusetts right now, such as the ACL Caregiver grant that Massachusetts Executive Office of Elder Affairs was just awarded, and there's some exciting work going on at our Department of Public Health and a number of other things. It's really, there's a real critical mass of people interested in caregiver supports and respite right now. So, and then finally, time is really of the essence because the ARPA timeframe is so short. It's coming to an end in March of 2025. So we at the MLRC are really hoping to be able to play a key role in continuing, to disseminate and build upon what PCG learns. So lots going on. It's very exciting. Next slide, please. So just very quickly, we released a request for applications for innovative respite services in, I think, late 2022. And again, as I mentioned in the previous slide, it was really we were looking for people or applicants who were talking about or proposing creative or experimental ways to address unmet respite needs. There was a tremendous amount of interest in the program. We had 167 applicants with a total funding request of $42 million. And we ended up awarding 40 grantees, totaling 18 million for a wide variety of respite initiatives across the state or across the Commonwealth. Next slide, please. And then just a quick overview, and then I'll turn it over to Sarah. So as I mentioned earlier, the real priority areas in this funding announcement were to develop and implement new or enhanced respite models, provide person-centered respite services, improve diversity, equity and inclusion among respite programs, recruiting and retaining respite workers, and also implementing programs with strong evaluation components in order to measure the effectiveness of some of these programs. So we had a lot of some pretty lofty goals, and we've made some great headway towards really learning a lot from these grants. So with that said, I will turn it over to Sarah, who will take it from here. You can move on to the next slide, please.
Thanks so much, Amy. Can everyone hear me okay?
Yes.
Perfect. Okay, great. I had some last minute technical difficulties. You can go on to the next slide. All right. So as Amy set up, we supported a grant program that ended up providing 40 really different, very diverse respite programs. And a cornerstone of our evaluation for this program is our biennial performance report. So this will be a bit of a theme throughout our presentation. It was challenging to develop an evaluation that could help us understand the wide scope of services and innovations being provided and implemented, and the lessons learned from these when they were 40 very, very different projects. The performance reports, this is a lot of information here, but it gets to a lot of the demographic data that we've talked about in the past day and a half, and starts to delve into some qualitative data that feeds other aspects of our evaluation. Next slide, please. Great. And additional evaluation methods to build on top of those performance reports include quarterly meetings. These are learning collaboratives that I've heard a number of different organizations talk about how important these are to set up with a variety of organizations performing similar respite programs. The way we set up these quarterly meetings was we pulled all of the grantees at the beginning of the project and identified the areas that were of most interest to them. And then we set up quarterly meetings with specific topics called learning communities. Generally, we pulled in 1 or 2, sometimes 3 grantees who were really on the leading edge of these specific topics and highlighted what they've done to do a good job in specific areas, and then hold a panel discussion for grantees. So the primary goal of these learning collaboratives was really on the technical assistance side to support grantees with meeting each other and coordinating with one another and building off each other's lessons learned. We did find, however, that they were a really, really great source of qualitative data that we will be building into our final evaluation. The next phase of our evaluation will be focus groups, and those are actually coming up in the next couple of weeks. We've got 3 different focus groups in early November. And then the final component of our evaluation plan is a survey specifically for caregivers. So asking grantees to forward this survey directly to the caregivers that were supported, so that we can hear directly from caregivers for our final evaluation. Next slide, please. So we really appreciated the opportunity to review the work of the CAR, and I wanted to highlight the ways in which our project and the evaluation model that we are working through now aligns with the value of respite model presented by CAR. So first, to just start on the context phase of the value of respite model, the design of our grant program itself really allowed for the contextual variation based on the initial organization. So the organizations that won these grant awards and are implementing innovative programs were really responding to the specific context that they saw in their communities and with the folks that they worked with, and are really designing that respite program to meet those needs. Next slide, please. We've talked through a little bit over the last day and a half about the factors, the process factors that really all need to be in place for respite to be particularly effective. And we wanted to highlight a few areas where this has really come across in the Massachusetts innovative respite programs. The first is that first phase of helping individuals identify as a caregiver, or ensuring that individuals are identifying as a caregiver. We actually have 2 out of our 40 grantees are really specifically focused on marketing and outreach, specifically to make sure that they are reaching out to individuals in the community who are providing this intensive care to individuals with needs in their families and in their lives, and helping them understand that there are supports for caregivers available. One of our grantees actually is Archangels, which I know some folks, and they were a great speaker at the conference, the ARC National Respite Conference for Raising the Bar for Respite. And they are one of our grantees really supporting the Boston Senior Center to help outreach to the community in which they serve, and helping to build, helping more individuals identify as caregivers and take that first step of taking a caregiver intensity, getting their caregiver intensity score. The second area is acceptance of respite. We heard a lot in our learning collaboratives about the need to and the process of really building trust in our communities. This came up again and again and was a really important theme, that building that community trust and the specific ways in which that is done over time, and with cultural competency and care to acknowledge and reach out to individuals with the diverse linguistic and cultural backgrounds was a huge component in developing successful and effective respite programs. And then another area that I wanted to highlight was access to services that meet the family's needs. The majority of the grantees are identifying that their model of respite increases flexibility for the caregiver. And that occurs in a few different ways. One example that I can provide is we have a couple of different grantees whose innovation is to eliminate that barrier to respite, especially in emergency situations or in last minute situations that might not necessarily meet that tier of emergency. We have one grantee in particular that's eliminated wait time for respite to day programs. So there's no longer the wait time to be accepted into a day program. And that is really identifying and meeting the specific family needs. Next slide, please. In terms of the outcomes, the value of respite, we are collecting data in a few different ways to help make sure that we are aligning with the best practices and gathering data on the benefits and the outcomes of each of these 40 individual programs, as well as the collective impact of all 40 innovative projects working across the state of Massachusetts. So first of all, we've mentioned that these are really different projects. So as part of the application, organizations actually identified their own custom metrics to help them measure, track, and evaluate their own programs. So those custom metrics were identified as a baseline metric at the beginning of the program and are collected in those biannual performance reports. Many of these metrics include satisfaction surveys. We identified that early on. And our first learning collaborative actually was working on providing some resources on free and evidence-based caregiver assessments that organizations could implement, often in place of or hand in hand with the program satisfaction surveys, to really get more evidence-based feedback on the value of respite for those caregivers. And then finally, one of course, the outcomes that we do need to include in evaluation and understand is the financial cost and impact analysis. And our final report will identify an average cost per caregiver per respite, per category of respite model. Next slide, please. All right, I know we're short on time, but I do want to touch base on the core concepts aligned with the value of respite model. So the CAR has put forward the core data elements, and a number of these are reflected in the data that we have already collected. So if you can go to the next slide, we'll show from our second performance report, we started to receive some valuable data. Again, we're looking forward to implementing the focus groups and the caregiver survey, which will provide more context. But we do have a good understanding so far of the demographics of the individuals who are supported and impacted by these programs. So 21% of all of the caregivers were over 65 years old. On average, 34% of caregivers served by grantees were over 65, and a few organizations were specifically dedicated to supporting these older caregivers. Next slide, please. We're particularly interested in the program design and making sure that respite programs and innovative respite programs that we're growing across the Commonwealth, we're taking into account the needs of individuals who speak languages other than English as their primary language and who have diverse cultural backgrounds. So we are capturing data on primary language spoken by the caregivers. In our latest report, 12% of caregivers served were speaking a primary language other than English. For 25% of the grantees, a quarter or more of the caregivers were speaking a primary language other than English. Just a note, we did not capture in the performance reports ethnicity, race or ethnicity data. And that was a conscious decision at this point because those performance reports are submitted by the grant organizations, and we don't have a consistent mechanism of gathering that data directly from caregivers. When we implement the caregiver survey in early winter, that we will have that race and ethnicity data for caregivers, but wanted to ensure that we were getting that data directly from the caregivers rather than through the organizations who are supporting them. Next slide, please. The most frequently served group is individuals over the age of 65. And notably, the caregivers are being caregivers who are supported really are across the lifespan. So while there are a majority of individuals, or a good amount of individuals over the age of 65, we're also seeing caregivers supporting younger adults, individuals with developmental disabilities, and all across the lifespan. Next slide, please. And we are collecting some process measures that help us identify and define respite factors. For example, 18, we are identifying caregivers who are supporting care recipients with complex health conditions. And we're able to identify that we do have caregivers across all of our grantees who are supporting individuals with complex health conditions. And also we're identifying some of the diagnostics of the individuals who are receiving care. So you can see that 29% of caregivers are supporting an individual with developmental disabilities. 17% are supporting individuals with behavioral health needs. And of course, that can be co-occurring with other diagnoses and making those individuals categorized as individuals with complex health conditions. And then finally, 16% of our caregivers are supporting individuals with Alzheimer's or a similar condition. Next slide, please. We were particularly interested in respite innovation categories. So back to the theme of 40 very different projects that we are working to evaluate. One of our first steps is really identifying the categories of respite. Because we're short on time, I won't go into too many details here, but I will say that we are seeing a lot of location-based respite services. We're also of note, we've got 6 organizations that are providing caregiver to caregiver services, which are a unique model that we're working to better understand what are the key success factors in that model. We've got a number of organizations who have a marketing and outreach component to their work as well. And next slide, please. Finally, we're gathering at a high level outcome data regarding the number of caregivers who we are supporting and who are impacted by this program. In the second program period in the last 6 months, more than 3,000 caregivers were served because of this program. Next slide, please. We are particularly excited that of those more than 3,000 individuals who were supported, 22% of were caregivers who were receiving respite supports for the first time. So that again really shows that a lot of these programs are finding new and beneficial ways to reach out to new networks and to really serve individuals who hadn't traditionally accessed respite programs. Next slide, final slide. All right, and next steps, again, we are sort of midway through this evaluation. We've got the focus groups and the caregiver surveys coming up. We anticipate a final comprehensive report in April of 2025. So we really the final evaluation report by June of 2025, because we've got final performance reports in April. We're really looking forward to sharing those more in-depth results with all of you. And then, what are the next steps and implications for the Commonwealth of Massachusetts? These were funded by one-time ARPA dollars, but this evaluation is really designed to make sure that there are findings that can be incorporated into future grant planning, that it can really inform the ongoing work of the Massachusetts Lifespan Respite Coalition, or MLRC. And that the MLRC is now really posed to take the lessons learned from this evaluation and build on them through networking and learning collaboratives moving forward to really build on the work that has been done through these innovative grant programs. Thank you. And I know we'll be holding on questions. We've got one more group of panelists.
Thank you so much. It's so exciting to hear about all the great work happening in Massachusetts. And wow, over 3,000 caregivers already served in that 6-month period, and almost a quarter being first-time respite users is amazing. So really excited to hear your preliminary results on that, and looking forward to hearing more when you complete the project. We are again going to, as was mentioned, save questions for the panel Q&A, but if you have questions that you don't want to forget, feel free to pop them in the chat, and our panelists can look at those and respond if they're easy to respond via chat. And we are going to move on to our last panel presentation. Very excited to have Linda Weiss here, who is going to share more about the Exhale program, the Family Caregiver Initiative Evaluation. So I'm going to turn it over to Linda.
Great, thank you, Kim. Yeah, I'm going to talk about the evaluation of Exhale, which is the Family Caregivers Initiative. I'm a researcher and evaluator at the Center for Evaluation and Applied Research at the New York Academy of Medicine. Next slide. So just to start, I'd like to give a little background on Exhale. So the program operates in Western New York, primarily rural communities, and Southeast Michigan, with financial support from a group of foundations, including, but not limited to, the Ralph C. Wilson Foundation, the Health Foundation of Western and Central New York, the Ann Arbor Community Foundation. And Exhale is managed by the Philanthropic Initiative, which is also known as TPI. The initiative provides grants and a variety of other supports to the grantees, including a learning collaborative and assistance with project development, project management, communications, and of course, evaluation. It launched in 2019 with a pilot. There were 3 projects in the pilot, and that's referred to as cohort 1. They were all in Western New York. The second cohort, which is now in its 2nd year, has 13 projects, and the third cohort with 11 projects is just beginning. So in this presentation, I'm going to focus on cohorts 1 and 2. Next slide, please. So a little more background. In order to be funded, Exhale requires that organizations collaborate, that they solicit and use caregiver input in the design of their programs, and that they participate in a series of creative problem-solving workshops. Exhale, like the other presentations, strongly encourages innovation, although standard models are respected and sometimes funded. The assumption is that one size or even 2 sizes does not fit all. And here's a list of some of the innovations, the programs that have been funded. So caregiver and care recipient, engaging in respite opportunities together, individualized technology-based respite that's not bound by time or place, a broad range of programs and services, music, household chores, wellness activities, and thinking about brief periods of respite rather than longer programming where you might need to drive somewhere, drop somebody off. Next slide, please. So now to the evaluation. So we at NIAM have been serving as evaluator for Exhale since it started in 2019. And our evaluation is guided by these 4 aims. So assessing changes in access to and use of respite among caregivers of older adults, building the evidence base to better support respite needs and innovative respite models, documenting the development, implementation, and significance of new collaborative partnerships, and examining the Exhale model overall and its component parts. In this presentation, I'm going to focus primarily on numbers 1 and 2 with a little bit of 3. Next slide, please. So I've tried to focus on components of the evaluation that are most relevant to this summit and to the work of the Arch National Respite Network. So listed here are the data sources that I felt were most pertinent, which are, to be honest, the majority of the data sources. So we have caregiver surveys, and the grantees are responsible for having caregivers complete the surveys. Our preference, and what most grantees are doing, is a series of baseline 3-month and 6-month surveys, which are linked with a unique identifier so we can track participants over time. Some programs use their services more of a drop-in model, and they feel that they wouldn't be able to track people over time. So we've developed what we call this single activity survey. And that's completed by participants at each event. In addition to the surveys developed through NIAM, sites have the option of using the Archangel's Caregiver Intensity Index, which was just referenced in the last presentation. And several are doing that. So in very general terms, for those unfamiliar, the Caregiver Intensity Index documents caregiver burden and factors that impact the burden. We also do interviews. So we do interviews with a convenience sample of caregivers each year. We interview grantees each year and members of the Exhale leadership team. We're interviewing grantee collaborators at the kind of start of a project and at the end. That is specifically focused on collaboration and network growth. We also review grantee proposals and reports so that we can gather additional information on the funded projects and their progress. Next slide, please. So going a little deeper into the caregiver surveys, this is the kind of data we collect on the surveys. So caregiver, care recipient, basic demographics, some information on health and wellness at baseline and follow-up. So general health, some very basic information on mental health. We have been collecting some healthcare use data. It's not, to be honest, showing much, so we might not continue that. The caregiver intensity using the Archangel's instrument, which is optional. And then we do ask information about respite experience, whether they've participated in respite programs before, motivation for participation, frequency of periods of respite, and at follow-up, satisfaction with and impact of the respite programs. Next slide, please. And then in the caregiver interviews, we try to go a little bit deeper to understand caregiving responsibilities, their participation in respite programs, primarily the Exhale programs, but other programs as well, motivation, experience, and perceptions of the programs, and then their perceived impact, like reduced stress, access to additional resources, connections to other caregivers. Next slide, please. So I'm going to talk about findings. So I'm going to first talk about findings from one of our cohort 1 projects, Caregiver Tech Solutions, which is led by Healthy Community Alliance, a rural health network in Western New York. So this project began in 2020, and we have pre and post data for 121 participants. And listed here are some of the key components of their programs. Not surprisingly, they provide tech solutions, including things like cameras that can be placed throughout a home, door alarms, electronic tablets, and other resources, which they determine by individual need through a caregiver assessment. They conduct coaching sessions to design and support the respite solution and do follow-up to see how things are going, to measure impact, and provide referrals. And just to give an example of how and why such a program is categorized as respite. So one of the caregivers that I happened to interview explained that she was caring for her mother who lived alone in a multi-story house. She had some mobility issues. So cameras were installed on the staircase, allowing the daughter to know that her mother had safely navigated the steps each day and night, meaning that the daughter did not have to go and check on her mother, and also giving her peace of mind, and that she didn't have to worry. So that removal of responsibility and peace of mind was her respite. Next slide. So these are some of the selected program impacts at the 3-month follow-up. Virtually all participants in this program report knowing about and having new opportunities for taking a break from caregiving, having new resources to support them as a caregiver, and feeling supported knowing that they can take a break. Next slide. So another set of outcomes. So we look at periods of respite in the last month, or we ask the caregiver about periods of respite in the last month. And you can see an increase of respite at least once a week from baseline to the 3-month follow-up. So 50% at baseline, 73% at follow-up, which which is statistically significant, the change. Next slide. So this is one last slide for this particular project. This project is using the Caregiver Intensity Index, the Archangel's instrument, and so comparing again baseline to 3 months, we see a statistically significant improvement, particularly in the people reporting being in this high caregiver intensity. So the kind of top line there, 34% had high intensity at baseline compared to 14% at 3 months. Next slide. So now I'm going to switch to cohort 2, which hopefully is not too confusing. Now I'm going to be talking about baseline. So for cohort 2, there are more programs, but they're obviously started more recently, so we don't have as much follow-up data. Still, I wanted to share some of the data we've collected so far. So there are 9 programs doing the baseline follow-up model, so we're happy about that. 3 programs have this more of a drop-in model, so they're doing the single activity survey. And just showing some numbers on the surveys we have completed so far. We've also done 16 caregiver interviews with this particular cohort. Next slide. So this is some of the findings from baseline. So most of the caregivers are age 65 or older, 27% are 75 or age 75 or older, 72% women. 39% feel worried, nervous, or anxious daily at baseline, and 66% had never participated in a respite program prior to this one. The care recipients, primarily age 75 and older, 68% are 75 or older, 28% were over age 85, and again, primarily women, 56%. And just to break it up a bit, here's a grantee quote talking about some of the challenges just in kind of getting people started. So she says, some of the hurdles are convincing the population that they truly are caregivers and that it's okay to be vulnerable, which are 2 things that this population struggles with. And kind of quoting or paraphrasing, probably, a participant, I'm the rock, I don't have the option but to be the rock. Next slide. So this is some more data from baseline. These are kind of reasons or motivations for participating. And as you'll see, most 60% or higher want new opportunities for the person they care for, new opportunities to take a break for themselves, resources to support caregiving responsibilities, and help with coping with the stresses of caregiving. Next slide. So this is the cohort 2 version of one of the charts I showed earlier for caregiver tech solutions. So this is again selected program impacts. For cohort 2, we added I'm better able to cope with the stresses of caregiving to the instrument, and that ended up to be the highest proportion agreeing with that. 88% say that because of the program they're better able to cope with the stresses of caregiving. Next slide. So this is again, a kind of cohort 2 version of a chart you saw or table you saw before. And again, we see increased use of respite over time. So 57% at baseline, 67% at 3 months, 78% at follow-up. And the ends are different, but we did an analysis where we matched, so same end across, and looking at where we did match, this is also a statistically significant increase in respite use. Next slide. So this is a little qualitative data on caregiver impact. And so the first one is a program where the caregiver and care recipient participate together, primarily serves people with dementia. And so the caregiver is talking about his wife, and it says, if I can see my wife having a good time and singing and smiling, yeah, that's even better than a couple of hours off. So this model where people are together, for him that worked better. And then the second one, I won't read the full quote, but she in the beginning is kind of hesitant to say that the program benefits her. It's like, oh, this is for my mom. She loves it. It's great for her. But then she realized, as she participated, that how much better she felt knowing that she could take her mother to this program and not worry about her, and that increased her patience, reduced her level of guilt, and then so improved her well-being. Next slide. So switching from the individual to the organizational level, which is an important part of our evaluation. So as I mentioned at the start, Exhale requires that projects represent collaborations. So there's multiple reasons underlying the requirement, including the belief that it's important to build respite into the organizational ecosystem of the communities served, that collaborative projects are more likely to be sustainable, and that they are in the end more efficient. For example, you don't have to provide transportation if you can collaborate with a program that already has that capacity. So here's some information on collaboration within Exhale. So the first cohort obviously had more time to develop collaborations, which might be why their numbers are higher. So they have an average of 12 collaborators compared to an average of 5 in cohort 2. I will also mention that one of the cohort 1 grantees has many collaborators, 22, and that might also be the reason that the averages are different. But and then approximately half of the collaborators receive funding through the grants. And listed here are some of the roles and responsibilities that they have. So outreach, advertising, referrals, resources, programming, and advisory. Next slide. So we're developing network maps, and we'll look to display, so this is just a sample, like the most basic one. So we're looking to display different characteristics of the networks as well as change over time. So like we'll look at growth, we'll look at involvement of diverse sectors. And in this map, so this is a cohort 2 map, the blue squares are the grantees and the green squares are their partners. So you can see some of the grantees are collaborating with one another. Some of the partners are collaborating with multiple grantees. So that's just kind of a preview of work that we're doing. Next slide. So we, of course, ask about collaboration in our interviews as well and hear about the value, but also the challenges of collaboration. So on the value side, there's, of course, the direct services, and that's represented in the top quote. Beyond that, organizations have really appreciated getting to know one another better. They increase knowledge of services available in their communities. And in some cases, they've noted that collaborators are assisting with efforts focused on sustainability. But there are, of course, challenges. So most concern commitment and control, as well as some extra work that collaboration requires. Several noted that commitment waned for some of their partners over time, either due to staff changes, like maybe they had a champion and that champion left and the other staff is not such a champion, or just the passage of time and the shift in organizational priorities. Next slide. So just a very brief summary. Our preliminary findings point to growth in access to and uptake in respite, multiple models with positive impact, and expanded networks of organizations supporting caregiver respite. Next slide. So I just want to make sure to acknowledge and thank everyone. So all the staff and caregivers in Excel programs, the funders, and this is the full list of funders, and the philanthropic initiative, which is, again, managing this fairly large initiative, and other program partners, including Archangels and some other groups. And next slide. So this is just contact information. If you would like more information about the evaluation, feel free to contact me. And if you would like more information about Exhale, John Tyler is the person to contact, and I believe he's on the call now. So that's it.
Thank you so much, Linda. That was a great presentation overview of the evaluation work being done on Exhale in New York. We are now going to move into our panel Q&A. So I know there's been a few presentation or questions being posted in the chat that have been responded to. So I will try to skim through and find ones that we haven't discussed about as well. But please, everyone, feel free to continue to post your questions in the chat and we'll get to as many as we can. I just want to start out with my initial question. Thought it was amazing how all of you were able to show alignment with the value of respite model that was developed by the CAR. And I know we asked you to do that, but it was great to see how retrospectively the work you're doing aligned with that model. And I'm curious if now, after seeing the recommended common data elements and thinking about additional opportunities to align with the model, if there are opportunities to modify or add evaluation metrics in your projects to further strengthen that alignment and use some of the common data elements. Just wondering if there's any thought or consideration to that potential to continue to strengthen the alignment across these great national projects by using common data elements. Any thoughts from the panelists? Yeah, Linda.
I can start. So I think that, I'm sorry that I didn't go through the model. I felt like we had too much already. But I did feel like we do align a lot. I think where we have a gap, and I look forward to looking more carefully and using the model, is around describing the interventions. So that's something that we have not thought carefully about how to categorize them, and I think that will be very useful.
Yeah, thanks for that, Linda. I think you did a great job showing the alignment, and I think it's a testament to the strength of the model that even without, having that model prior to designing your different projects, that it does align. I think it shows that it's universally applied in a lot of respite evaluation research settings, and I agree that the two tools that were developed by the CAR, the caregiver experience with respite and the description of the respite model, I think are particularly useful tools that if we all had those, like years ago, it would have been really helpful for us to consistently define and compare and showcase what it is we're talking about when we talk about respite. Rebecca, you look like you have something you want to say.
Well, sure. And there's also a message in the chat from Jill about with CDRI, are we able to link the outcomes from the caregivers to the specific types of respite or amount of respite that people have? And the short answer in our research design is no. We are basically aggregating outcomes to the level of organizations. And so we are not able to look at exactly at an individual level of how much respite, what kind of respite did somebody get today or during this period? Did it have the intended outcome? So that's just sort of the nature of how we have many different organizations that are doing different kinds of respite. So we will be able to identify the kinds of respite that they're providing, but we won't be able to look at it at an individual level in our design.
Yeah, thanks for sharing that. Any other panelists want to speak to that? Otherwise, I'll go on to the next question.
Yeah, Sarah, unfortunately, Sarah had to drop off at 4, so I'll answer where I can, but she's really the evaluation expert for Massachusetts, so.
Great. Okay, great. Just again, looking at questions that I don't think have been answered in the chat, we have a question from Virginia. As when it comes to providing respite services and hours for our caretakers, are there existing jurisdictions or models we can look to for inspiration? Any panelists want to speak to that?
That I can speak to. I think, once we go through the evaluation that Sarah described for the 40 Massachusetts innovation grants, we hope to have, I'm speaking for Sarah, but I think this is accurate. We hope to have a report that can be shared, with other states, and certainly would provide some models and some best practices for sure over, later in 2025.
Yeah. And
I think also with the CDRI project, one of the things that we want to do in addition to just reporting sort of pre and post changes on those outcomes and the types of clients being served, we want to create a compendium of innovative respite models, which are the ones that appear to be most effective, that are most sustainable, based off of our interviews, as well as the data we're collecting through the evaluation efforts. So that is hopefully a deliverable that the CDRI evaluation efforts can produce over time.
Thanks for sharing that, Becky. I think what's interesting about that with all the evaluations, and I'm curious across all the evaluation projects, how you're measuring the fit to the family's needs, right? We talk about a lot about the context matters. That is it person family centered? Is it culturally, linguistically appropriate? Is it meeting the family's unique needs, right? Because there's such a variety in how we can provide respite and the models that we have. And we know that not every model of respite works for every type of family and their context. And so I'm curious if any of you are accounting for that in your evaluation to look for that sort of match, that fit to their unique needs as a part of that evaluation.
Kim, in my own personal research, this is a topic I am very interested in when we are looking at respite outcomes at the individual level. For this evaluation effort, it was really cumbersome to think about including all of those details in the data collection forms that we had. However, we do have a couple of open-ended questions. All the respite that we are doing are for dementia providers. So we ask, do you believe that your respite needs will change over the course of dementia and what does that look like. We also asked some open-ended questions of the caregivers and families of what kind of respite do you want now and in the future? What are the most important things that you like? So we're hoping to get more of those narrative examples from caregivers themselves.
Great. Anyone else want to chime in, Amy?
Yeah, just to follow up on that, I think the focus groups that Sarah talked about that PCG is going to be conducting starting next week will definitely, that's going to be one of the topics. And I think as Dr. Utz said, I think a lot of that will be more, qualitative, to some extent anecdotal data, but it'll be really helpful. And I think we've definitely identified that as a key factor. Also with some other respite, ARPA funded respite grants that DDS, that my agency have done over the last year. We've really struggled with that the readiness of families to accept respite and making sure that it meets people's needs. It's easy to develop a program and then, when you build it, they will come kind of thing. But I think cracking the code or whatever the phrase would be to really try to customize and help people accept the respite, anything that we can learn in that area would be extremely helpful.
We're not collecting that kind of data, and I think our numbers would always be too small to be able to really have any kind of reliable findings. But at the program level, like the grant reports that are submitted, they're required to talk about caregiver input in the design, and if they're having trouble with engagement, then there are resources to help with that, and hopefully, if the program is a better fit, engagement will be higher and more consistent. I did want to mention that I put, in response to the question about examples or models, I put the link to the Exhale website in the chat, and it shows all the programs that have been funded as brief descriptions.
Thank you so much. I see Dr. Gaugler has his hand up.
Yeah, one thing I think to note here in all of these conversations about evaluation and considering respite in general is when you talk about person-centeredness, Kim had raised the question about, are we evaluating whether the respite program is meeting the individualized needs of the care partner, or perhaps client, and others as well. And, I would imagine many programs do this in different ways, do this fairly well. I mean, in terms of trying to ensure that the needs of who they're serving is met. I think where this overall research on respite has been challenged and has been challenging to find effect is many of the outcome measures we use aren't individualized at all. They're not personalized measures of effect at all. They tend to be standardized measures, often developed in other contexts for other healthcare services, that don't match what respite really often is designed to do and provide. And so in order to show effect of these programs, I believe our outcomes have to be similarly personalized, and that's easier said than done. I think many funders aren't necessarily comfortable with those types of measures, at least at this point, although many more are getting to that point. But if you really want to show effect and you really want to show, okay, these respite programs work in addition to adhering to rigorous designs, and I noticed in the chat there were some comments made about evidence-based versus evidence-informed, which I think is very important to remember here, is also to ensure that the measures we select are measures that can be changed and can be influenced by respite. And oftentimes, I would argue many times the measures we include are so distal that they can't be influenced, and then we end up in the same place we've been at for really 30 or 40 years, which is, is respite really working or not? When in fact, I can ask all of you, I could probably walk into all of your programs and you can find out fairly quickly, yeah, it is working. I mean, we know it's working from just anecdotal, qualitative observation, but how do we move to get to the empirical outcome understanding that, yes, it is working? I really do believe it's the personalized outcome measure strategy.
Yeah, thank you for sharing that. I actually wrote down, we need to measure what matters and have those outcome measures informed by the caregivers, which is something we talk about in the to our work as well, and so important. So even when developing the recommended common data elements, I think we struggled a lot because there's a lot of things we want to measure, and the measures that do exist, you know, they're great in other contexts, like you said, Joe, but we really need new measures. And so Sarah Swanson and I are like, we could spend the rest of our career just developing respite measures. So if anyone else wants to help us with that, I think it's really important for us to think about that as a potential implication and next step, that we need to have better measures that are applicable to these settings and can capture some of that, the unique flexibility that is needed to have those customized measures. So really appreciate that comment. I want to just come back to a question that was posed earlier by Franz, that at Easter Seal Miami, we incorporate the AmeriCorps Legacy Corps program for veterans and military families, and our goal is to alleviate caregiver stress and foster resilience, ensuring that caregivers and care recipients thrive. Most families have a family member in a stage of dementia, and ask what would be the best tool to assess the caregiver's effect on the program's effect on caregivers. We use the Nazaire burden interview as a benchmark. Are there other tools to look at the change in caregivers? So thoughts from many of the panelists? I can just say that. Yeah, go ahead, Linda.
Yeah, I would just say, I mean, for us as evaluators, we don't have one, we don't use one large tool. It's, like other people were saying, it's a couple questions from here, a couple questions from there, because there's so many domains we want to cover and we want to reduce burden. I do know that one of the Exhale programs was very interested in resilience, and I'm not sure what tool they decided to use, but I could look into that.
Yeah, and in the common data elements recommendations, we do recommend Nazaire as one of the measures. Again, there's other measures. A few groups that were presenting today talked about the caregiver intensity scale that we looked at, but because we tried to not have proprietary measures in our recommendations, we wanted things that were easily accessible to people. We did not include that as a recommendation, but again, encourage you to take a look at the recommended measures that are in the Common Data Elements white paper, because we list pretty explicitly what we think are currently the best measures for different outcomes, recognizing that may change as new measures are developed moving forward, and we just talked about the needs of those. Great, we got a lot of questions about sharing tools and questions, and we already had some of that information shared in the chat, but just I think a general request to any of the presenters, if you have the ability and interest in sharing any of your surveys, questions, anything that you think might be helpful for others to look at and replicate, feel free to share those with ARC, and we will make sure we get those out and available for folks to learn from. So appreciate your willingness to share on that. I'm just scanning other questions that maybe weren't asked. Again, feel free to post questions, or if you had one buried early on that I didn't get to, repost it so I can find it. There's a lot of great dialogue in the chat from people, lots of great sharing of information. So I encourage you to skim through the chat as well. Jill, did you have a question?
I did. When Joe raised the issue about customized measures, excuse me, and then you elaborated on that, could you provide a few examples of what those might be, other than the ones, we're looking at, like stress and anxiety and health status? What would those additional measures be that might help us better determine how effective the respite service is?
Yeah, I think, and Joe had to step off, so I can't speak for Joe, but in my mind, the general idea is that we should ask caregivers what they think matters and measure it, and have them help inform the development of measures and scales that will help us to better understand the value of respite and the outcomes that it produces in their own world. So we need to develop them, because the measures that exist are kind of global general measures that have been used in other settings, not specific to respite care. And so the caregivers themselves may be the ones best positioned to help inform the development of those measures. And I think it's a good segue to our conversation tomorrow about ensuring that we have community engaged research and are looking at cultural and linguistically appropriateness of the work that we're doing.
Just a quick follow-up on that, though. We do need to have measures also that funders and those who are responsible for expanding services will understand as well.
Absolutely.
So that would be quite a balancing act.
Well, and I think that those caregiver informed measures would need to still go through the rigor of being validated and deemed reliable in evaluation and research studies. But it's just the input onto the development of those, I think it would be really important to be from the caregiver perspective. And I see a couple hands up, so I'm going to call on Becky Epps.
Sure. I just wanted to give an example. Jill, you're asking, like, what is a specific example? So one of the outcome measures that we use is a standardized scale, the desire to institutionalize. It's a set of 4 or 5 questions. We measure it before the caregiver starts using respite, and then again, a year later or whenever they finish their engagement with that respite provider. Because the CDRI is a cooperative agreement, we had input from the funder, and they said, you know what? We like that you have the standardized scale of desire to institutionalize, but can you just ask them a question compared to now, or compared to when you weren't using respite? How do you think about institutionalization? Have you thought about it? And so they wanted a very specific question of just saying, before you use respite versus now, what are your thoughts as a caregiver? So that's
like
just an example of how we have a standardized scale and sort of a direct question to ask the caregivers.
That sounds like a question right out of Arch's evaluation guide from the year 2000. That was
That's
a question we asked.
Awesome. Susan.
Yeah, I just wanted to bring up, we never talk about this with respite, but single subject research can be very powerful. And it's a goal attainment scaling is a kind of single subject research. And when Becky S. presented years ago about coaching and time use, I mean, I thought right at that time, wouldn't it be great if the caregiver talked about what their priority and goal was? You're checking back constantly. So that's your goal. That's part of what you're measuring. Your antecedent is the coaching. And then every time you check with a caregiver, you find out whether or not they got the right support, whether or not they've changed their mind on the goal or priority. And when you do that over time, you see how their needs change, you see how what supports are most effective. And in the aggregate, I've used this before in a respite program, it's powerful in the aggregate because you show individual progress and you reflect some of that person and family centered service. It can't be the only measure, but I tried to get the programs in the evaluation project to do this, but it was like one thing too many. But I wish there were a couple programs in the country who would try this. I would help them.
Yeah, thank you, Susan. I see Mary Beth has her hand up.
Hi there. I'm Mary Beth Barrett from Canada at Westway, and we've been doing all different types of evaluations and some research for quite a few years now. But one thing I've noticed a lot we do these family focus groups where we invite families out, and this is probably about 14, 15 years worth of time, especially in pretty basically remote or smaller community areas. We tend to do more like a qualitative family focus group arrangement. But one of the things I hear, I like how somebody just had said about ask caregivers what matters. And one of the really common ones that that comes up, and it especially comes up with our senior services, is we want help with snow removal, grass cutting, and house cleaning. You know what I mean? So it's I know that people say, well, that's not respite. Well, it is to these families. So it's kind of interesting to see. And I don't know if anybody hears much of that in the States. I don't know if that's a common thing that comes up, because our challenge then is how do we creatively get that done with keeping it without getting the ministries after us, because that's not respite. It's got to be to the person. So I'm like, okay, well, have the person supporting your family member and sit outside in the garden and you could talk as you do the garden together or so. And, we're always trying to find other ways to make that work. But is that something that or is that a need that's already taken care of in your system in the States?
Yeah, great conversation. I'm wondering if I could ask Becky to share a little bit because she does some work around this and kind of redefining respite. If not, I can take it, Becky.
Well, no, but this is sort of stepping back further, not even just sort of asking people what matters to them, but asking people what is respite for them. Every single person, every caregiver that is being served by respite is going to define respite as a service that comes into their home to give them a break to leave the house. For other people, respite may be a moment of meditation that they have to take during the day. And so I think that there is a pretty significant change in just defining what respite is. And maybe that is not, maybe that's what we have to ask people, is what is respite to each caregiver before we even evaluate the effectiveness of that respite, but what are they doing for their respite services? So
Yeah.
I don't know if that's sort of where you were going when you called on me, Kim, but maybe you can add in more.
Yes, yeah. And I think we talked about this at D1 yesterday, a little bit about how, you know, there's respite as a formal service, that sort of the traditional respite service that has different innovations, that is very important to have available for people. And then there's also other things that can create respite as an outcome for family caregivers that we need to, you know, understand the importance of both, but making sure that we are very mindful that it's important to continue to fund formal respite services for family caregivers and not say the answer is informal respite and help people learn how to meditate and they'll be fine. Like, right? Like that's an important piece, but that's not all to it. And we could talk for hours about all of this, and I'm sad that we are running out of time. I do see Lori from ACL with her hand up, so I will give her a minute. Then I'm going to have to wrap us up today, and please post other comments in your chat if we didn't get to you. So, Lori.
These are not closing comments. This is like my favorite topic. I just read an article about a group here in Maryland in our next county, kind of like a Meals on Wheels like a volunteer program. They've started a volunteer program to have people mow the lawns of elderly people needing assistance. And they have already 80 volunteers. And, you know, they can live in their home, but they can't maintain their homes. Not necessarily, I mean, it's still respite because it's like this lady was, the example was this lady was a gardener. There's another program where here in the States, high school students get service learning hours. And they've worked with the schools to recruit students to do that kind of work for their service learning hours. And then, well, in one of our grant programs, because I oversee the Lifespan Respite Care Program here, I don't know if you were here yesterday, there's a guy for his respite, he wants to go fishing. And so that's what they do. That's what he does. And they're like, can we do that? It's like, yeah, because that's the way he gets a break. He's not, but school identifying students, it's not hard work and they can get community service hours or whatever. And then a brand new pilot program in the next county, kind of trying to mobilize a community of volunteers to go out. And probably there'll be snow too, but we don't get it you do, but we do get it. I'm only 64 and trust me, I'm like, tell my 27-year-old son, you'll be shoveling because I've been there, done that, cross it off my list.
Well, it basically, when you think about it, it's like, oh, don't worry about stress, anxiety. I can't get out of my driveway, or I can't, you know what I mean? Like, I think the more we make other ways of applying respite, then we really are listening to what caregivers want. So who are you to say what I want or need, and who are you to say what I want or need? And I had somebody, they wanted an oven because with convection oven in it, because their wife, even though she has dementia, she liked to bake, and she thought that would motivate her to get back into doing a little bit of something that's meaningful for her. But I think that's one of the things I'd love to see, is not defining how it has to be spent, or not defining how, having a very liberal idea of how, and that's again, family directed respite funding, not having as many rules on how that's applied, and who am I to say how you're going to spend your respite? So how do you measure that? That would be fun from a research point of view.
That's why I love this topic, because it's make it happen. Make it happen, Mary Beth.
Yes, yeah.
Well, I think, oh, go ahead, Mary Beth.
No, that's okay. Go ahead, Kim.
I was just going to say, I think that's part of the challenge we talked earlier about, how do we how do we measure that informal, those other things that provide families with the outcome of respite? And it's really respite as a package of tools, right? And for many families, having a formalized respite that allows them to have, physical separation from the person they're caring from is really, really important. I will never forget a few weeks ago at the National Conference on Caregiving Research at UPitt, a caregiver said for her respite is every day when she wakes up before the sun rises and stands in front of her kitchen sink and washes her dishes. And she looks out her window and she feels the warmth of the water on her hands, and it's quiet and it's her me time, right? And so it's like I never thought of washing dishes as respite, but again, it's as defined by the caregiver. We are very much running out of time, so we have so much more we could talk about. We encourage you to continue these conversations offline and join us tomorrow. We're going to ask, I'm going to ask Marcia to share our day 2 reflection question. We would love for you all just to take a moment to post in the chat one key takeaway you have from today. What stands out is something you might have learned or are going to take back into your practice moving forward. We'd love to hear your feedback on that real quick. If you could pop a few ideas in the chat. While you're doing that, I'm just going to remind us of tomorrow's agenda. For day 3 of our Respite Research Summit, our topic is engaging respite programs. Oh, I'm sorry, that's the wrong one. Let me get the right one up here. It is culturally, we're working on cultural and linguistic competence in respite research. Thank you, sorry for that. And we have an incredible lineup of speakers who are going to talk about how we do that, some of the challenges, and give some exemplars from research initiatives that are applying some of the best practices in engaging in culturally and linguistic competent research and evaluation. So we hope to see you again tomorrow. The same Zoom link will work, and our day 3 final day of our summit begins at 1 p.m. Eastern, and hope to see you all again tomorrow. Thank you again for this robust discussion. Thank you to all of our panel presentations, to Susan for your excellent facilitation, and I will invite Jill to say a final farewell.
Again, I just want to thank all of our presenters for so many wonderful presentations and for taking time out of your very busy schedules to be with us today. And to all of you who are attending, thank you also. We know this is a big chunk out of your day, and we're just so heartened by all the compassion and interest and passion that goes into this work, and we thank you all for that.